Good afternoon. My name is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. Thank you all for joining us today to discuss MPN symptom burden. This is a big subject with lots and lots of information and discussion today, just for our little hour and a half, but it'll be chock full of questions and information. We have two wonderful MPN specialists joining us. Of course, our scientific advisor and frequent speaker, Dr. Ruben Mesa, will be with us, and Dr. Pettit, Kristen Pettit, is coming from the University of Michigan. She'll be with us at 1 o'clock. We also have three patients, MPN patients, that you'll hear from, Julia, Robbie, and George. And sometimes hearing from other patients is very valuable because they've had those challenges, some symptom challenges, some that they still experience, but some that they've been able to figure out how to deal with. And perhaps they might be able to share some information with you that will help. So to start, I just want to thank our industry partners. They have been fabulous with us during this COVID pandemic and sharing and helping us to maintain our business and keep going. I want to thank my staff, Kathleen Michael and Mallory Tim. They're fantastic people. We're small, but we're mighty. And so to begin here, I'd like to introduce, many of you already know Dr. Ruben Mesa, but I would like him to join us here. And hello, Dr. Mesa. And let me make sure, yep, he's on. And so without further ado, I'm going to turn this over to the specialist, Dr. Ruben Mesa.
Wonderful. Well, delighted to be here today. I always enjoy these events and look forward to our conversation on MPN symptoms. And I was just going to show a few slides to help frame our conversation today. And if you could allow me to share my screen.
Yes.
We're getting there.
Perfect. Were you able to see that okay?
Yep.
Wonderful. So let's talk a little bit about when we're talking about both symptoms and quality of life, and that they're both important concepts and important in today's discussion as we think about what symptoms MPN patients can face, how do medicines play a role in that, what other things outside of medicines can have an impact on symptoms. Now, symptoms sometimes are really used interchangeably with the topic of quality of life. The quality of life is a little broader concept and I think a bit more comprehensive. When we think about overall quality of life, it is much broader. And it's basically what is the gap between what we think our life should be and where it is in terms of a whole range of things. Now, as it comes to health-related quality of life, that is a subset. So all of us can be feeling perfectly fine, but we have some tragic thing which occurs to us. We lose a parent, or our quality of life may decrease significantly, but our health-related quality of life is the same. So health-related quality of life is really all those things related to your health. It can include financial stress. It can include hassle of medical care. It can include disease-specific symptoms. It can include any toxicities from a medicine. So if I have a medicine that takes away your itching, but it gives you diarrhea, is that a fair trade-off? Maybe, depending upon the circumstance, it might be. But what is the aggregate of all of these things that you face? Because we're never just one thing, we're everything all put together. Now, I've spent my career working with you and patients and colleagues trying to better understand what is the burden of having an MPN. It clearly includes symptoms. We'll get around to the symptoms are linked to the biology of the disease. They're related to high counts. They do matter. The spleen can be a problem, sometimes a significant one, more often in myelofibrosis. Lower blood counts can be an issue and they can add to symptoms. There clearly is risk of progression. That can be a big issue. There can be risk of blood clots or bleeding, what we call vascular events. And obviously all of these things occur in the construct of you as an individual. What is your age? What is your health? What is your baseline level of fitness? Our group has been very active in trying to develop standardized questionnaires so that we can assess symptoms in a reproducible way, using symptoms from fatigue, spleen, constitutional symptoms like weight loss, quality of life, have created questionnaires that have become the standard around the world. Additionally, adding in symptoms from high blood counts and mood-related symptoms to create the MPN symptom assessment form or the total symptom score. It's now been validated in well over a dozen languages, been tested at last count in about 50 different countries. Now, what we see is that once symptoms are common, they're not universal. Not everybody with an MPN has symptoms. They're not necessarily progressive. So some individuals have a lot of symptoms to start with. They get controlled by medicines. They don't necessarily get worse, but they are common. And fatigue is by far the most common. Myelofibrosis overall being the most symptomatic, with perhaps itching being a bit of an outlier, being the most common in polycythemia vera. Not all symptoms are the same. Certain symptoms to me suggest risk of progression, particularly weight loss, fevers, bone pain. I associate these things more with movement toward myelofibrosis, where things like fatigue can be present in all three of the diseases. The symptoms can evolve over the course of the disease. There are times when a patient's diagnosed with inflammation, vascular events, they feel poorly. We start medicines, they might feel better. All of the medicines we've used in some individuals have helped them feel better. Hydrea can help people feel better. Phlebotomy have helped people feel better. Aspirin can help people feel better. Everything we do sometimes can have an impact. Symptoms can wax and wane as things evolve over time. Iron deficiency from phlebotomy can be a negative. Blood clots, medication side effects. So it is a constant tension, if you would, between the status of the disease, between possibly the medicines or approach that you're having, between the stage of the disease, as well as the rest of your health, overall impacting how you feel. Now, people have asked, well, do MPN patients really have symptoms? When we first started this work, some physicians were skeptical that their patients had symptoms. And to validate that this was indeed the case and that they are more than the general public, you'll see on the left, we did a study with colleagues in the United Kingdom that showed that compared to the general population asked the same questions matched by age, MPN symptoms, all of the symptoms are much more common in the general public than in MPN patients than the general public. We also are able to validate that the questionnaires, they're pretty accurate. So as you look on the right, that is matching the symptoms in US patients versus UK patients, seeing that they're almost identical. Part of the driver of symptoms might be, at least in part, inflammation, that acting in a range of ways may be an important trigger for some of the symptoms that are experienced. Now, people have also asked the question, well, they're having symptoms, is it just related to anxiety or concern about the disease? It will be honest to say that that can be a factor. Without question, knowing many of you as I have over the years, having an MPN is an uncertainty in your life. Is it going to get worse? Am I going to live on my normal lifespan? Is it going to interfere with my ability to maintain my employment, see my kids graduate from school? It's a stressor. We clearly try to decrease that, but to say that that doesn't exist would be inaccurate. So that can be a factor, but there's also a strong biology factor as well. Now, as we think about fatigue, we have learned that there clearly is a relationship to biology. There are a variety of medical pathways related to counts, the levels of cholesterol in the blood, cytokines in the blood, and mood that may impact fatigue. Abdominal symptoms can have many different contributors. The physical size of the spleen, the dynamic of the spleen, prior blood clots, different elevations in inflammatory markers such as cytokines, all may lead to a range of different things. Also have learned over the years that patients can have both irregular bowel habits or sometimes irritable bowel symptoms, sometimes exacerbated by their MPN or if they have enlargement of the spleen. Constitutional symptoms have many different components. More often in myelofibrosis, weight loss can be a hallmark feature of myelofibrosis. And unfortunately, not the weight loss that we want. You know, in our society, one, none of us lose weight without trying. So when we do, it's usually a concern. Unfortunately, it tends to take muscle over fat. So it's not even the weight loss anyone would want. And it occurs for a range of reasons. Eating less, potentially inflammation, potentially increased burning of calories and other cytokines. Other things such as fevers, chills, and night sweats can have a range of different cytokines that are involved with developing those symptoms. Microvascular symptoms. These are the ones related to higher blood counts, decreased ability to concentrate, sometimes difficulties with reading, headaches, itching, sometimes issues with sexual dysfunction, sometimes issues with painful areas on the skin, a range of different ties to biology. Now, we're going to discuss throughout the course of today medicines, how medicines fit into the equation. And we're going to hear from some industry partners for MPN advocacy for a range of medicines that are all in development, that all have as part of how they assess the effectiveness of their therapies, whether in myelofibrosis or in PV or in ET, do they also help to reverse the difficult symptoms MPN patients face? Now, in parallel with this, my group has been very interested in, well, what else can we do in terms of non-pharmacologic interventions to aid with symptoms? My colleague, Kristen, who's now at University of Arizona, has been doing some great work. And one of these is an article that they recently published looking at questionnaires, asking individuals like yourselves, you know, what sort of things have you been trying to help with your MPN symptoms? And seeing aerobic activity, support groups being amongst the most common, but people really trying a whole range of different things. We performed a landmark study. Indeed, in terms of symptoms, what are the things people would reverse if they had a chance? And the number one in all three MPNs was fatigue. Clearly, there can be other examples, but fatigue is probably one of the most challenging, with individuals trying both exercise frequently as well as non-prescription supplements. I've been involved with a group trying to use yoga to aid this. We've done a couple of trials. Maybe some of you have participated in these. And with these, we have seen significant improvements in a range of difficulties, symptoms, and inflammation. My colleagues at Mayo, Arizona, Leslie Paternos, continues to move forward with the MyACT study, which is a cognitive intervention to try to decrease the stress of the disease. I also been working closely with my colleague, Jen Huberty at Arizona State University, where she's the scientific director for Calm, which is an app that does meditation. And we've done trials showing ability to aid difficulties with anxiety and symptoms, but also likely improving sleep and improving inflammatory markers. There's great interest, and I'm sure there's questions. woven into what Anne has there regarding dietary changes. And we'll discuss that in a bit. And there are some dietary studies that are ongoing and some work that has been being done by Dr. Angela Fleischman out at UC Irvine, where she's also looked at supplements trying to aim at inflammation. So with that, there are many of us really committed to the cause of trying to improve the quality of life for MPN patients. We recognize that it's a long journey, it's a chronic disease. There's a range of issues, both as it relates to both medicines and non-medicines, and look forward to today's discussion and panel. Thank you.
Thank you so much. Oops, am I on? Thank you so much, Dr. Mesa, and stay right with us. At this time, I just want to introduce the 3 MPN patients that will be with us today. Here's Julia. We're looking for George and Robbie. But Julia, do you just want to share briefly, you know, your experience? You've been around for a long time, as I have, and just your experience briefly, and then some of the things that you've had challenges with that you were able to overcome through whatever process, either therapies or home remedies, or, you know, whatever you'd like to share.
Oh, I'll try to keep it brief because, as you said, I've had myelofibrosis since 2008, and then ET for a diagnosed year before that, but probably for many years, you know, in retrospect. So I guess to sort of some of what Dr. Mesa said, I've sort of been all over the map. I have had years of extreme symptoms, intense fatigue, so that walking across a room was exhausting. I would sit with my hands in my lap because literally holding them up would be tiring. In 2013, even though I was working, you know, full-time career and traveling and had 5 combined children and a blended family and a nanny and 2 dogs, et cetera, I had to take a part-time route. So the disease has absolutely affected, I think, my career trajectory and the kind of work I might be doing. And I've had probably a handful at this point of hospitalizations for TIA, for colitis, for example, and that's probably the worst pain I've ever had. But in any case, for me, finally, through all of the available medications, 5 years of Jakafi made a significant difference. It made a difference very quickly in terms of my fatigue level and the pain that I was feeling in my extremities. And I am now one of those maybe rare people on the spectrum of, I think I'm going into my 3rd year of no active treatment. And I'm taking a baby aspirin and a Lipitor, and then some supplements. And although my MF is now acting like PV, so phlebotomies are now, you know, my new friend. I think otherwise my fatigue levels, pain, et cetera, is much lower. And I know my MPN expert won't exactly speculate because we don't know why that is, but I'll take it. And in terms of the kinds of things I do, I'll just list a few of them. I have always gone to therapy, or at least since I've had this illness. Being able to see a therapist virtually has been wonderful through the pandemic. And I have other things that I need to talk about. I have a blended family, which is complex, although now very wonderful. But having a chronic illness at times has really brought me to some very dark places, especially when you're really feeling unwell. It's very hard to persevere, and it's almost exhausting. It can be exhausting emotionally to push your body when your body really doesn't want to. And yet there aren't the obvious outward signs telling others that you feel like crap, as I would say.
Yeah.
But so keeping the head doing well. The other thing I've always done is I walk every day. Even when I felt awful, I still tried to get out. I might have just walked less. Anne and I know we've talked about this. I'm very fortunate to have a place in the countryside that I can get away to. And it's so restorative to just walk and see trees and breathe fresh air. I'd live in a city otherwise. And just the other few things I'll say is I have tried intermittent fasting, mostly to lose weight because I did gain weight during my Jakafi years. I'm understanding that Angela Fleischman and team are evaluating the potential, I guess, inflammatory reduction possibilities. So I welcome that, but it has helped me keep my weight in a better place. You know, I also have tried medical marijuana when my pain was at its worst, and I encourage people to make use of it. And, you know, pain is exhausting and debilitating. And if it's available, then I was willing to try it, and it has helped me. So those are just some of the things that I would say are useful.
Thank you very much for that information. And joining us also, you see two other faces on the screen, and I'm going to put George up here, I hope. Let's see. I don't know how to do that, so I'm going to have Mallory do that. But oh, there you are. Good. Okay. Hi, George. So joining us, I'd like to hear a few moments from Robbie, who is also an MPN patient, and her story is very unique. Some of you may have heard it at one of our events, but Robbie, if you have, if you would like to share what's working for you. I know you're going through a transitional time right now, which I'm very sorry about that, but there's great hope also. But if you'd like to share a few moments too.
Of course. So my journey began about 6 or 7 years ago when I was just sitting there watching TV and I broke out in quarter-size hives on my legs with no other explanation. I hadn't eaten anything new. It was just kind of very strange. A few weeks later, I was at work and all of a sudden I got vertigo and nearly fell over. I had to leave, and I decided to see a doctor because I had never experienced vertigo. So I went to the doctor and she's like, well, vertigo is usually a virus. Don't worry, it will go away. And if it hasn't gone away, come back and see me. She never ordered any blood tests or anything to follow up. My vertigo stopped, luckily, and I just kind of dismissed it. The factor that made me kind of suspicious was I was brushing my teeth and I saw a little bit of pink blood when I spat the toothpaste out. And I'm a dentist, and I knew there was no other reason for my gums to bleed. I don't have gingivitis, gum disease. I get my teeth clean. All the check marks were there. And a story from one of my professors in dental school came to me that a dentist might be the first in line for treating or being able to help diagnose a blood cancer. That always stuck in my head because I was like, oh, that's interesting. So when my gums were bleeding, I got really scared. I ran and ordered myself a blood test, and my platelets came back really high. I said, well, that must be a lab mistake. I went and ordered another one a few weeks later. It was even higher. So at that point, I started doing some research online, putting my symptoms together, and it was textbook ET. So I basically walked into a hematologist's office and said, could you please test me for these mutations? I think I have ET. He did. And even before he tested me, he wanted me to start an agrolide immediately that day. I decided to leave that office immediately because I had read enough and I was educated before I even went to that appointment, knowing that's not the first line of treatment and I needed to have a diagnosis before I start a drug. And given the fact that he was so quick to jump to treatment and they called me by the wrong name and the phlebotomist came in to draw for something else, I was like, okay, this is not the office for me. And then I went to another office for a couple of years, and she wasn't very comfortable treating me because I tried HU and it didn't work for me. I wanted Pegasus and she wasn't comfortable with Pegasus. So I crawled into Dr. Catriona Jameson's office, and I am so blessed and lucky to have found her. She started me on Pegasus, and that kind of helped for a while with my, I had some side effects, but it was better than my fatigue and all the itching and the tingling and the numbness. Until the January of this year, where I felt a very quick change in my health. I'm very aware of my body, and I could feel my spleen. I had a lot of bone pain. The fatigue was back, like there was no tomorrow. So I went in to see her, and she ordered a BMB. And unfortunately, I went into MF stage 1 to 2 with some collagen fibrosis. So I started Jakafi about a month and a half ago, and I haven't really noticed any big changes, except my spleen pain is better, but I'm still fatigued, and the fatigue is just the hardest part for me. And I exercise, I eat healthy, I juice greens every day. I walk every day, I do strength training, I do yoga, like nothing I do is really making me comfortable. So I've decided to cut back on my work, which was a very, very hard decision for me. My practice has been my baby, but I want to do a good job. And I just felt like being that tired, I couldn't do a good job. So now I'm kind of a part-time, and that's helping. The stress of dentistry is a stressful job, and trying to take more time for, yoga, meditation, and all of that. So, in June, we'll see. I'm seeing my doctor again, and I'm hopeful that we'll come to a solution or a better treatment option for me then. But I'm very lucky to have the support group of all of you guys and my fabulous doctor.
Yes, you do have a fabulous doctor, and a fabulous other doctor just joined us. Dr. Kristen Pettit is with us. She's on the screen. Hi, Kristen. We'll get to you in 2 seconds. I want to hear from George. George has visited us at our Cleveland Clinic programs in the past. And George, could you share, you wrote a little piece for one of our newsletters recently, and you shared that, you're doing this, and I thought, you're a good person to maybe share some things with the patients out there that are having some issues. I can't hear you. It's on your end, George. You got to hit the microphone. Can't hear you. I can't hear you. So let's have Mallory help you, and I'm going to go to Kristen. Hello, Kristen. Are you with us?
I'm with you. Hi, everybody. I'm so sorry to have to have joined a little bit late. I'm sorry.
That's okay. We understand physicians have crazy schedules. Ruben shared that he had 6 Zoom calls already this morning. So
I think we're tied, Ruben.
So we so highly appreciate and respect both of you and your time. And so, Kristen, do you want to share with the attendees what's going on at U of M, but also, anything you're noticing with your MPN patients that they're doing or you're encouraging them to do that is helping with some of the symptom management?
Sure. Well, thanks so much for having me, and thank you so much for putting on these events. I know I get a lot out of them, and I'm sure all the participants get a ton out of them too. It's so great to hear everybody's stories and get all these excellent questions that come through too. I think these events are really important. Yeah, I'm a physician at University of Michigan here. You see my Michigan sign behind me in Ann Arbor. I've been here for about 4 years now, focusing on MPN specifically. I do mainly clinical research, so mostly clinical trials, new drug development for patients with ET, PV, and myelofibrosis. We do have a lab here as well that does a lot of work behind the scenes too, with kind of figuring out some of the biology behind the disease, testing new drugs in the lab, figuring out how they work or don't work, figuring out the roles of different cells in the bone marrow and the way that they contribute to myelofibrosis formation over time. So that's another avenue that we have here. Another avenue that we're focusing on here that's pretty unique is that we have a really excellent radiology group down in the basement who are trying to study whether or not we can use MRIs to detect fibrosis and measure fibrosis over time in the bone marrow, and potentially down the road, if that's a good way to follow the disease, which we don't know yet. But if it is, perhaps be able to spare people some bone marrow biopsies down the road as we're monitoring for myelofibrosis development or progression. That's our goal, at least. So that's a shameless plug that if anybody's in the Michigan area and would like to participate and have a one-time quick MRI scan, please reach out to me. We are actively trying to validate this technology and see how well it works. Including actually, if you have any family or friends who don't have any bone marrow disorders, we're looking for some normal bone marrow to do some MRIs on too. So they wouldn't let me get in the scanner since I'm part of the study team. But if anybody knows of anyone who is interested in looking for relatively quick and easy ways to help out, please feel free to send me a message and we'll help coordinate that. So all of those things are ways that we're here trying to advance the field and make things better for patients. Did you want me to talk a little bit now about experience, or do you want me to wait?
First of all, George, can you hear us? Can you talk and see if we can hear you?
I can hear you.
Oh, there you are. Yay. So Kristen, can you hold yours just for a second? And George, can you briefly share with us, as I mentioned earlier, some of the things that you had shared with us a while ago about things that you do to manage your symptoms?
Yeah, no problem. I wrote an article and it really encompassed how I discovered this particularly rare cancer. And about 5 years ago, got out of the shower and was itching. And bottom line was I thought the cause was a harsher soap. So I changed soaps like 3-4 times, not knowing that this was one of the symptoms of this rare disease. So as I went through a normal function of yearly physicals, which everybody should be doing, the normal blood test came up a little bit different. And then the redo of the blood test was done by the physician in charge, the PCP. And he said, you know what, your numbers are gradually going up. So let's just be sure about this. I'll send you to a hematologist just to be safe. As it turned out, the hematologist was very, very knowledgeable. But once again, he wasn't the specialist of the MPNs. He did discover that I had PV, and that was a little bit of a wake-up call, and that was about 5 years ago. Even though he was treating me at the time with Hydrea and the 1 aspirin, and watching the symptoms, and the bottom line was, being in the medical field for like 40 years, I wanted to make sure that I was going to the best person possible. I don't want to go to a podiatrist if I have a headache. So I hooked up with Dr. Gerds down at the clinic. Fortunately, that's very accessible to us because it's close by. And I do that about once a year for him, as well as keeping in touch with you and your MPN programs, because you know what, nothing is better than the specialists that you have for our particular rare disease. So I highly endorse that. The side effect profile can be overwhelming, as we've heard with these 2 previous patients. And I'm experiencing as many as are available as far as the symptoms are concerned, the worst of which is being short of breath. And that's scary. And when you do that, even with exercise, it still comes on you. And possibly it's related to the fact that the spleen is enlarged, as well as your hematocrit, my hematocrit, is elevated, which gives you higher concentrations, as we all know, of the red blood cells, who are sticky and larger and don't transfer oxygen as readily to the system. So you almost know when your next phlebotomy is going to be needed based on the fact of the symptoms occurring with the shortness of breath. So what I do is I treat it like I use it like a car, basically. Once a month, 6 weeks, I will go for blood work. And if in fact the blood work shows hematocrit at 45 or higher, as we all know, that shows check engine light to me on my body. So that's when I go and walk to get a phlebotomy done. And usually after that's done, the symptoms, dissipate a bit as far as shortness of breath. It's a challenge. I think just saying what all the other patients were saying, one of the biggest challenges besides being shortness of breath and the symptoms is looking normal to other people and them questioning why you can't participate in certain things, whether it's a nice big meal or being in the sun, or why are you warm, why are you leaving the house because you need air, or that type of deal. And sometimes I feel like plastering the symptoms across my forehead, for those people who know what the particular diagnosis is. So, but endorsing the fact that I go and listen to you, listen to your specialist, Dr. Mesa, Dr. Pettit, the information as well as the introduction for new treatments for this rare disease is invaluable. So it gives us hope, because this can be a very depressing and challenging emotionally disease state, because once again, it is a rare blood cancer. So with that, I'm here for any particular participation that you would like me to do, Anne. And I really appreciate it.
Thank you, George. George, we appreciate you and your support too. Thank you very much. And all three of these patients. We're going to go back to Kristen. We have so many questions. We might just plow through these, but I want to go back to Kristen. And Dr. Pettit, if you'll share some of the things you have witnessed with your patients and how they are managing with some of the major symptoms, for example, bone pain, itching, those things that come up all the time.
Yeah, I think what strikes me the most about these diseases in general is how different everybody's experience is with these disorders. I mean, really, you won't find two people that have the same constellation of symptoms and the same things that they're going through necessarily. That's why I think these groups are so helpful, to know that you're not the only one out there with various different symptoms like this. So because of that, I don't think there's a one size fits all approach to any of these symptoms or any of these issues. But I think I love all the lifestyle modification things that have already been mentioned, staying active, cardiovascular exercise, yoga, mindfulness or meditation, nutrition. I think all of those things go a really long way physiologically in helping to control some inflammatory aspects of the disorder that cause some of the symptoms, and also mentally giving you a sense of kind of control over the situation to the extent that you can. So I think those are all really helpful. I think that some of the newer treatments that we have can be, in some people, hugely helpful to control certain symptoms too. Certainly the JAK inhibitors like ruxolitinib or fedratinib that are out there have been game changers for some people, but it's a very mixed response and not everybody. And I think, I have a lot of hope that there are some different treatments coming down the road that are being studied right now or will be studied shortly that will have hopefully an even bigger impact or a broader impact on some of these symptoms for people. So I do think that a lot of the treatments that are in clinical trials right now work differently than JAK inhibitors, which is, I think, great to see that we have some other avenues, some completely different targets for therapy that might be able to make an impact on some of the other symptoms and aspects of the disease that the JAK inhibitors don't touch as well.
So Dr. Mesa, you mentioned in your presentation, and this has become a huge subject, and I know Dr. Fleischman's done a lot of research on inflammation, and I'm hoping she'll join us in Washington, D.C. for the women's event. But from your perspective, because I remember several years ago, a patient coming to us saying, I'm just going to work on the inflammation. I'm going to get a doctor that will give me an anti-inflammatory drug, and I'm going to change my diet and do all these things. And actually he did very, very well for a couple of years. And then I think it kind of waned. I'm not sure why, but his disease either progressed or something. But can you share what your feelings about inflammation and what patients can do?
So one, I think what you raise is important. I think inflammation can be a part of the difficulty and symptoms, but it's not the whole equation. It's multiple things. I do think that the number of increased cells themselves have an impact in terms of blood flow and a range of things, mechanical impact from the spleen, actual things from the bone itself. Some of the bone pain really might be a physical piece, even in terms of the bone activity. And then there's also inflammation. I think there are a range of things that really can impact inflammation. One that we probably don't speak enough of is sleep. There are a variety of things that we have worked on that it's been fairly clear by their benefits in several diseases, that the main reason that they improve things is that sleep has value. It is restorative for the body, it decreases inflammation, and a lot of people have a lot of problems with quality sleep for a range of reasons: sleep apnea, restless leg syndrome, and a whole variety of things. So if somebody's sleeping 4 hours a day, there's almost no medicine I can give them that's going to make them feel great. So sleep is really important. Second is diet. Now, people ask me, which diet should I do? I would first put in the category of, if you're trying to do anything with your diet, you're probably better off in about 80% of the US. So it doesn't matter what diet it is. Any structured diet probably is better than the majority of the US diet, which is, way too much meat, tons of carbs, no balance in terms of nutrients. Now, amongst the diets, which one is best? I suspect that there may be a lot of individuality. There are a lot of people who feel better gluten-free, whether they have truly gluten sensitivity or not. There are many investigational approaches, intermittent fasting, keto, on and on. Very difficult to say which of these might be best. Is it something that you actually can do? Again, you shouldn't have to live for your diet so that it's so restrictive that it interferes with your ability to, see people, go out and enjoy a meal with others. So I think there are aspects of that. The simplest recommended US diet is what's called the Mediterranean diet. As I've interacted with a bunch of folks, try to eat. I'm like, oh, Mediterranean, do you mean like bukas? I'm like, no, the Mediterranean diet, think of more like, a bit like a Greek restaurant, grilled fishes, a little bit of meat, vegetables, olive oil, feta cheese, a little bit of wine, a range of things. But that's probably been felt to be overall one of the more healthy and balanced diets. So I'd say there's probably lots one can do with inflammation that really is not around medicines. What probably is not a good approach is to try to either go for steroids as an anti-inflammatory, because they have a range of negatives that probably far outweigh any positives, nor is there really any benefit or safety to pure anti-inflammatory drugs like Aleve or Advil or things of that nature. Probably are not really kind of the approach.
So there are 3 Mediterranean people sitting right here, all 3 of us. Anyway, and my mom lived to be 95, I might add. But so what I would like to ask now, and Kristen, I'll turn this to you. So Robbie, I don't know if you heard her story, but Robbie was not well. but was doing great, and working out and eating properly and yoga and exercise, and has progressed to MF. And so what do you say to a patient like Robbie, who was doing all the right things. I mean, this train that leaves the station and there's not much anybody can do, but what do you say to a patient like her?
I would applaud you for doing all the right things. Absolutely. Because, not everybody is doing that. That's for sure out there in the country. Like Ruben said, I mean, you're going far, far above and beyond what most people are. And I'm sure it's making a difference, and I'm sure it's not easy. So I think all of those things that you're doing, I think, are fantastic. And I think anyone who's having some of the same symptoms would highly encourage you to try to do something similar, even if it's just small lifestyle modifications. It can make some degree of a difference at least. I think another thing is to be realistic about your body and your expectations. There's only so much that's in your control. That's true, and it's a lot of it is not necessarily going to be perfect with lifestyle modifications. I'm hopeful that it sounds like you haven't been on the new medication for that long. So I'm hopeful that maybe some patients and a little bit more time will help. We do see people feel better, certainly on JAK inhibitors oftentimes, and it sometimes happens quickly and sometimes doesn't happen quickly. Sometimes it's a slow, gradual thing. So I think being patient and having that realistic expectation. It sounds like it was so difficult for you to cut down on your work. And I know I have a lot of patients that we have that conversation about that too. And it's difficult. I know it's difficult, but I think managing your expectations of your own body and resting when you need to, I think is really important. So I think all those things sounds like you're doing the right things. I for everybody out there that's experiencing similar things, fatigue is the number one symptom that we hear about, the number one symptom that patients report to us, absolutely, and the most severe symptom that patients report overall. So I wish more than anything that I had a magic pill or a magic thing that you could do that would make that go away and that would bring your energy level back to where it was before. Realistically, though, we don't have that. I'm very hopeful that it can get better with lifestyle changes, with medications, JAK inhibition, hopefully a little bit more time. For anyone who's out there who's struggling with anemia that's causing some of their fatigue or related symptoms, we have a variety of different ways that we can manage that. I think anemia is a very difficult and tricky thing to manage for people we're typically talking about myelofibrosis now, not so much ET or certainly not PV at that point when we're dealing with anemia. But we do have a number of different medications that are now available or different strategies to try to accelerate the red blood cell production and try to kick that into gear. And sometimes that can make a difference as far as energy level and other symptoms go. So that's something to make sure that you're bringing up with your doctor is whether your anemia can be better controlled.
Okay, so Dr. Mesa, 1 second, Julia. So Dr. Mesa, we have a ton of questions here and several of them talk about bone pain. What can I do about bone pain, but also itching, and not just itching all over your body, but specific itching on one's bottom. And is this a side effect or symptom that is different than the particular all over itching, or, but the bone pain. So if you can address both of those, and then we'll talk to some others here, but we hear about bone pain from patients all the time, and they're taking different things to try to help subside the pain or decrease the pain, but also the itching. So those are two huge subjects.
Great. Well, I think it's important for people to realize on here that again, you're thinking about it the right way. I mean, looking at each symptom somewhat individually can be important as well. Because they can be both driven by the MPN, but sometimes not necessarily solely related to the MPN, or they might be independent of the MPN. I try to tell my MPN patients, if something is changing with your health, let me know. We can sort it out. It may be unrelated. I've had patients that have had worsening anemia, and we found that they had something completely different. There was unrelated to their bone marrow disease, but we needed to be certain that it wasn't related to the disease and to try to get to an answer. Now, bone pain, when we speak of the bone pain from MPNs, it tends to be one a bit, as I've heard people describe that I think is accurate, kind of like growing pains, kind of like a mid-bone ache. It does tend to be very different than, let's say, sharp joint pain. Sharp joint pain, unfortunately, we're all getting to the age where we can have osteoarthritis. There are individuals that clearly can have inflammatory arthritis. That's more rare, but gout, in the feet or in the toes, a red swollen joint with rheumatoid arthritis. Those are different. Those unfortunately still can occur, but it tends to be more all over. It can be in the long bones. It can be across the ribs. It is more associated with myelofibrosis, not exclusively, but it is one that I tend to be a bit more concerned. Is it a sign of progression? It sometimes really can respond to better control of accounts. So that can be interferon, it could be hydrea, it could be a JAK inhibitor. It might be any number of the investigational agents for myelofibrosis. But we think that in terms of the biology, it's probably a bit that the bone is exquisitely sensitive to any increase in pressure, and I think the origins of it are, as there's more activity within the bone marrow, literally within the bone, even any slight increase in pressure within that bony space might be enough to really kind of cause that ache. Now, the itching has as its origin, I don't think we still fully understand, but it seems to be evidence that subsets of white blood cells can go to the skin, and there where they have chemicals and other things that they have that are involved with the immune response may trigger the itching. There have been studies that have shown that it could be monocytes, it could be basophils, a range of things. Itching responds really well to JAK inhibition with ruxolitinib and the other agents. It certainly can improve with interferon. Some people can have some benefit from hydrea in earlier disease as well, but the other two are probably more impactful. It also certainly has benefited sometimes from non-MPN therapies. Certain antidepressive drugs have had a benefit in itching, specifically Paxil and the serotonin inhibitors, the serotonin reuptake inhibitors, in part because serotonin in platelets may be part of that itching phenomenon. It also can be exquisitely sensitive to therapeutic UV light. So if I have a patient who's really desperate about their itching, the fastest way to get them relief sometimes is to put them in a tanning bed. Now, it can be still hard on the skin. You can still get a sunburn. It still can increase the risk of skin cancer. It's not something somebody could do day in and day out. It clearly would be terrible for your skin. But it can be a really rapid way to quelch the fire of a bad itching spell on the way to having medicines hopefully control it better. Now, itching on one's bottom sometimes can have a different driver. Now that's actually much more common in our society than people talk about. But that's something I would discuss kind of with your primary care doctor. There are a variety of things as it relates to both skin, irritation, diet, and other things that can sometimes make that be, very problematic. So I would definitely work with your primary care doctor on that is a real thing that can be a big problem. In MPNs, it tends to be much more generalized. So if I tend to hear that itching is really intense in one spot, then I get more concerned. Is there anything that's driving itching in that area? That sometimes can be detergent. If it's a type of garment, it sometimes can be a specific exposure, allergy to a metal. It could be a range of things. So because it does tend to be a much more kind of generalized itching. If it's really intense in really one spot, probably has something else making it worse.
Okay. And for the sake of time, Kristen, I'm going to give you a new question because look at the pages of questions we have. So I'm going to bounce back and forth to the two of you, and then I'll have the patients give some advice or say some things here too. Does ET make acid reflux worse?
It's a good question. I do hear about acid reflux or GERD quite a bit in my patient population. I don't know that ET directly makes it worse. I see it a lot in patients with myelofibrosis where the spleen is starting to become large. The spleen sits right underneath the stomach. So as the spleen starts to grow, the stomach can't really expand as well as it used to. So oftentimes that results in kind of a backflow of some of the acid up the esophagus. So it's certainly common when the spleen starts to get large. I don't think it's an incredibly common symptom in ET and PV when the spleen is not in people when the spleen is not large, but it's certainly a common symptom overall out there in the United States too. So it may or may not be related.
Dr. Mesa, what is happening with CRISPR? Is anyone working on, JAK2 or, what's going on with CRISPR, period?
So CRISPR, for those not initiated, is one of which there are a variety of different tools for editing a gene that is changed, or gene editing. And there's interest in it in a whole bunch of diseases, and it's even been a plot in some shows. I saw a cop show the other week where that was about somebody claiming all sorts of magic they could do through gene editing. So it's even kind of getting out there into the movies. In short, it's started in clinical trials in benign hematologic diseases, where they're looking at, I believe, in some hemoglobin disorders, where they don't have to get rid of bad cells that are clonal or neoplasms, to see if it can work. Can you correct a gene? And in some of those diseases, if you can get 10% of cells to express the gene where none of them did before, you might make the situation much better. So with hemophilia, if you could increase by 10% the amount of factor VIII in someone's blood, it'd be huge. Or with sickle cell, if they could have 10% more normal hemoglobin, they wouldn't have a sickle event. So it's starting there because the technology is complex. There's also concern in terms of safety, which is why they go slowly, that if you fix a gene, are you going to disrupt another gene, and lead to something else, like developing a cancer if you edit genes? Because all of these things it's all a house of cards, if you would, in terms of how genes kind of interact and such. So I do think it's very much on the radar to eventually try gene editing with individuals with MPNs. It does make a lot of sense. There are a couple cautions. One, we do know that many MPN patients have more than one gene that has been changed. And we may or may not know all the genes yet that get changed with an MPN. So if you correct one gene, but there's other gene changes, does that correct the disease? So I think we'll get there, but there are reasons it hasn't started in MPN patients yet. A big part of that is in particular for safety, because the downside, if we edit the wrong gene or turn on the wrong gene or turn off a certain gene, we could have possibly a very negative effect for people. So we want to be sure that it's a pretty safe platform before we would have anyone go through with that.
To some of our global patients out there, we just heard from someone from India who would like to have a phone consultation with you, Dr. Mesa. Would you like us to send some information to this person?
Sure, that would be fine. But one of the advents of COVID that has been a positive that I think has had an impact in our world is that the ability of telemedicine visits has right. increased, including international. Yeah. Phone visits are terrible. They're not a very good experience, I think, either for the patient or the physician. But telemedicine visits, particularly with MPNs where you have the materials, certainly can have some value. So I certainly have done many of these, as I'm sure Kristen and others have.
Okay, we'll send contact to your office information. And so, Kristen, where did that question go? Oh, so we're also hearing from someone from the UK, and this person says they were diagnosed with PV and are JAK2 negative and have a rare gene. I haven't heard of this, EGLN1. Have I been under a rock somewhere? There is limited info here in the UK. Is there any more information from either of you? Have you heard of this gene marker?
Off of the top of my head, I'm sorry to say no. I can certainly dig into it and see if I can find some more information, but it's not something that that I know of offhand. But I don't know if Dr. Mesa might know. Dr.
Mesa, have you heard of this?
So it's not one that's been associated with MPNs. I did look it up very quickly, and it is related to HIF1 alpha. HIF1, this is a control system within the blood that looks at hypoxia or levels of oxygen that could potentially be involved with an increase in red blood cells. Let me talk just very briefly regarding kind of interpreting these genetic tests. So when you all get these reports, think of these genetic changes, and it's evolving, but in different categories. So first, there are the mutations that we call, quote, the driver mutations. That sometimes your doctor is able to order a panel that checks only JAK2 mutations, either V617F or exon 12, or MPL or calreticulin. They're mutually exclusive. So that's kind of the driver mutations. Most people have one of those three, but not all. Second, there tend to be extended panels that look from anywhere from 40 to even 150 genes that have been associated with blood conditions. And even there, they will typically report out mutations that we know have a link to human disease. And sometimes they'll have genes of undetermined significance, meaning it's abnormal, but we don't know whether it's related to anything or not. So there are, some things that it's a bit of an evolving science. But the body has probably these 20,000 genes. So even when we check that, it doesn't necessarily mean that there's no other genes that are changed. So it's an evolving science. But with this one, I'm not uncertain of any relationship to an MPN. There are other genes that might be related to a familial change in the blood counts, but does not necessarily mean somebody has an MPN. So there are familial reasons that there can be an increase in red blood cells, or an increase in platelets, or an increase in white cells, or other things. So there are familial things where it's a completely different gene. It can kind of look like an MPN, but it may not be an MPN.
And we know, I think I'm correct here, that there is a very small percentage of people with PV that are JAK2 negative, correct?
Correct. It's probably well under 5%, but it does exist. But typically we really try to be certain that is an accurate diagnosis, because it's just as likely that the red cells are increased for another reason, which in the US, the single most common reason would probably be sleep apnea.
So I would be remiss if I didn't ask a question about MPNs and COVID. So we have a couple of questions, that are pretty much the same, and that is they've had their first shot, didn't do so well. They're kind of afraid of the second dose, and so any feedback, Kristen? I'll start with you on any patients you're seeing after their first and second dose and how they're doing.
Yeah, I think it's been a really mixed bag as far as the vaccines go. I have many patients who have had no issues with the vaccines and have felt well, all the way out to people who have said, well, I was in bed for a day or two and I felt really miserable, but then I bounced back. And then a lot in between that range somewhere. It seems that if people have side effects with the first vaccine, it seems that the second vaccine tends to be a little bit better. It seems to be, in my experience at least, that people don't have, most people don't have a really bad time with both of them at least. But of course, there's exceptions to every rule. I think there are a lot of reasons, though, to stick with it and get that second dose. I think the blood clotting risks that are there for MPNs to start with, and then the extra blood clotting risk that COVID infection brings into the picture is my biggest concern for most people with MPNs during this COVID era. So I certainly think that for most people, the risk of feeling crummy after the vaccines is certainly lower than the risk of having a blood clotting episode or a bad outcome or a rough time through an actual COVID infection. So I would definitely encourage to stick with the vaccination series, and definitely encourage everybody to consider getting vaccinated unless your doctor has told you otherwise for any reason. And there aren't many reasons.
Okay, I agree wholeheartedly, and I'm sure we all do. Of the 3 patients here, have you all been fully vaccinated? And did you have any issues?
I had an issue on the first dose. I had a fever for 7 days. And I think it's because I was on Pegasus and I had a hyperimmune response to it, which is good, I guess. But it's the first time in my life I had to call in sick. I was pretty sick with it, but I persevered and got the second one, and I, stayed off Pegasus the week before, and I did fine.
Any other comments, Julia? Did you? Yeah.
Yes, I had the Moderna vaccine, and the day after the first one, I had terrible shortness of breath. For me, such a severe bout that I called Mpns. First time I've ever done that, and they were excellent. And I got them to call my MPN expert. There was great collaboration and multiple EKGs. We decided not to go to the hospital. It did fade, I would say, over the course of the day. And then with the second vaccine, I think I had a low-grade fever and chills and felt pretty crappy for days. But I had read enough to expect that I might feel sick, and I lost 2 people in my life. There was no way I was not getting vaccinated, but it was sucky for a few days. Yeah.
And George, did you get vaccinated?
Yeah, I got the Moderna as well. Before I got it, I checked with Dr. Gertz, and he said there shouldn't be any issue with that. But after the second shot, I was probably on the couch for about 3-4 hours because I just felt wiped out. So, yeah. But after that, really no issue, fortunately. So
good. And Dr. Mesa, you were going to add?
I just want to make a comment. So I agree everything that Kristen said. Now, people have raised the question that's clearly being discussed. I hear people with blood diseases aren't responding as well. What does that mean for us? So first, let me kind of clarify. So one is, we think about response. There are 2 sets of responses. One where the body makes antibodies that we can measure in the blood, and the other where there is a T cell response in the immune system that's a bit more difficult to measure. We do believe likely most people get some benefit from the vaccine, even regardless of what any of those tests show. Now, what I can share for you is that I am privy to unpublished data from a very large study that's been done by the Leukemia and Lymphoma Society, for which I have the honor to sit on their national board. And in that, the MPN patients that they have looked at the blood, their responses, even with MF patients on Rux, have been very good to the vaccine. The MPN data has been very, very good. The people that have the highest levels of not responding or low response are completely different diseases. So for Kristen's knowledge, this is mantle cell lymphoma, heavily pretreated lymphoma, people that have gotten multiple antibody therapies against lymphocytes, heavily pretreated CLL. So a lot of diseases where both the therapies and the disease really attack the very core of an antibody response. In MPN, since the issues are kind of really different, probably not a big barrier.
Okay, and I'm going to,
And
yes.
I'm sorry, can I just mention that my MPN expert also checked my antibody levels, and I was very happy to hear that I had antibodies to the COVID vaccine.
Right.
Great. Great.
And do both of you physicians here think that we will have to have booster shots, 6 months to a year?
I would think highly likely, because again, likely the boosters will be against further variants. It's less about losing your immune response against what you just had. And it's more that the target is just changing. So I would tend to think we'll likely have annual boosters that probably will end up being compounded with the annual flu vaccine, and you get it all together. What do you think, Kristen?
Yeah, completely agree. It's hard to know. It's hard to predict for sure. But yeah, I agree. I think that seems really a likely thing that's going to happen down the road. I don't know how long our antibodies will last and whether we'll need boosters to the same strains or not. But I think it's new strains, and I think booster shots against new strains is very, very likely.
I'll be first in line. So to both of you, Ruben, you talked about depression, that can be part of what a patient experiences. And we heard from our patients actually that mentioned that as well. And so, I'm assuming this is correct, but you all can speak to this. And that is that the anxiety and depression seem to be worsening the symptoms. And so would either of you like to speak to that?
We did a large study with Zen Senyak's group as a questionnaire study called the Fatigue Project. And Zen, who I think brings his gifts really as a journalist and a communicator, he asked kind of the provocative question that, prove to me that, the symptoms aren't just related to depression and anxiety. So we did the questionnaires, both with MPN symptoms and a variety of different questionnaires that are around these parts, and without question, it's not that it's universal by any means, but rates of depression, anxiety, et cetera, are higher in MPN patients for a range of reasons, both in terms of, appropriate concern for the future, but sometimes we realize we can have disproportionate anxiety as well. I think if it's present, it clearly can make things worse. I think clearly people can have both. What I share with my colleagues is being mindful that that might be present, and needs to be addressed. And sometimes it's addressed by good conversations with their physician trying to alleviate some of that concern. I mean, I've had ET patients fearful that the next day they were going to have acute leukemia, and I don't think that's the case. And sometimes we're able to try to diffuse some of that anxiety. Sometimes it is something that is a challenge and needs more formal counseling. It can need sometimes medication and support. Clearly, events like you're doing here and with education and feeling part of a community can help to decrease some of that as well. But it's important to have both things be addressed. There clearly are MPN patients who generally have depression, generally benefit from being on a medicine, and both their depression and their MPN needs to be addressed. What's been your experience, Kristen?
Yeah, absolutely. I think that we as the medical community as a whole are not always the greatest about proactively teasing out symptoms of depression, anxiety, sexual dysfunction, sleep issues, some of those things that don't always come up routinely in clinic visits. And I think some of the work that Dr. Mesa has done and his team, some of the publications and education that you've gotten out there about the prevalence of some of these symptoms and how much they can be impacting people's quality of life with these conditions, I think is hugely helpful. And I think what you can do as you know, being as patients, as being your own advocates or advocates for your family members, is being sure to be vocal about that if any of those types of symptoms are bothering you, because they may be playing a large role in your other symptoms. You know, everything's related. Depression and anxiety, of course, are related to fatigue and sleep and a lot of other things. So I think being vocal and bringing those things up and making sure that they're addressed, whether it is, like Ruben said, as simple as a conversation that can help diffuse some of those things, or formal counseling, formal cognitive therapy or mindfulness exercises or medications. All of these things can be, I think, super helpful.
Right. So one last question, because believe it or not, the time is flying. And I forgot that this wasn't 2 hours today, that it was just an hour and a half. But Kristen, I'll start with you. You know, over the years, I hear a lot from particularly women, and we actually did a survey and asked about headaches, okay, and migraines in particular. And we sent it to our entire database, and the results were what we thought they might be, just based on our experience, and that was I think it was 90% were women that said they suffered from migraines. And there have also been some, a study that was done about estrogen and migraines in women with MPNs. Can you address that?
Yeah, I think you're right on. I think headaches are an extremely common symptom for patients with these disorders across the board. But I agree with you about the observation that females in particular do tend to have quite symptomatic headaches. And there can be some differences in various different symptoms across the genders in MPNs, but I think headaches is one of those big things. I think they're multifactorial, like everything else in this disease. I think there's a lot that goes into that. I think some of it might be biologically related to the disease itself. I think some of it might be anxiety related to the disease. Some of it can be anemia related to myelofibrosis too, can certainly cause headaches. I think there's a lot of different reasons, and trying to tease out for each individual patient what is specifically causing the headache, if it's possible, and then trying to get to the basis of that. You know, treating anemia would be a much different thing than treating, you know, anxiety or depression or, you know, ET in general related to that's causing the headache. So I think that that is an important conversation to have, and often easier said than done, I will say. But curious if Ruben has a different approach to headaches, and especially in female patients with MPNs.
Well, you're right. It really, for some, can be incredibly challenging. I mean, certainly some people are more prone to headaches independent of an MPN, you know, and sometimes that is a factor as well. And there can be a range of contributors. But I do find that, you know, having the blood counts be solidly normal is really important, kind of first part of that equation. You know, people say, oh, I have chronic headaches and, you know, my platelets are, well, they're okay. They're at 650, you know, and I still have headaches, you know. So I think first thing I do is really, after the other things have been addressed, you know, is if they're on medicines, really try to have the blood counts be adequately controlled. The solid hematocrit, if it's PV, that's well under 45, the platelets well under 400. Sometimes people who are headache prone really do better if they're closer to 200 to 300, the white count's under 10, you know, be sure that that's really well addressed before we kind of go to other strategies. But, you know, not infrequently, we'll certainly have a headache specialist as part of the team, particularly if it's been someone who's been prone to migraines, has been on multiple approaches as it relates to migraine prevention or abortive therapies, you know, and frequently, you know, monthly cyclical hormonal cycles can sometimes be a real piece of this as well. And sometimes that really needs to be addressed as well. You know, some individuals might really be better off with controlling some of these things with oral contraceptives, or others, if younger, that sometimes they haven't gotten because of fear of their MPN. So sometimes it does take a team approach, really connecting with either their primary care physician, a neurologist, their gynecologist, if there's multiple things contributing to the headache pattern. And
that leads me to, we have to wrap up. I mean, and at least this portion of this program, because we're going to hear from our industry partners, but I do want to just interject that, you know, what Dr. Mesa just said, I try to stress this to every patient we speak to in groups and individually, to make sure that all of your physicians are speaking to each other, your specialists, your hematologist, your primary care physician, because they can get the whole story that way and put the pieces together, I believe. And that can be very useful and helpful. So I know my patients here wanted to say more, and I so appreciate your time and your agreement to show your faces and be present. And to Julia, Robbie, and George, thank you so much. And Kristen and Dr. Mesa and Dr. Pettit, you know, I know your time is so squeezed and so limited, but don't go away yet if you would like to stay and hear from, you know, we always say this these days, for the first time ever in this field, we have so many new drugs in clinical trials and so much hope. And we are trying so hard to offer that hope to all of you. And it's important that you know what's going on and hear from some of the folks that are with us today. And first we'll hear from Kristen Griffiths from Insight Corporation. Kristen is, Insight Corporation is a maker of Jakafi. Hi, Kristen, and thanks for being with us.
Hi, thank you so much, and the team and MPN A&E International for giving me a few moments to speak about our company and its commitment to patients. So we work and study these diseases on a daily basis, but really truly value these moments to hear from you, your voices, your questions, and what's important to you, so that, you know, we as a company can help be a part of the community to support you. So just a little bit of background on Insight. We are a Wilmington, Delaware-based biopharmaceutical company, and truly committed to making a difference in everything we do to support the patients. So through our scientific discovery, you know, rigorous science is truly at the core of what we do, to develop and deliver novel medications that will meet the needs of the serious medical diseases in the oncology space, as well as other spaces as well. Just a little bit about patient access. So one of our most important commitments is to help ensure that the appropriate patients may have access to the medicines that they need. And for this reason, we developed a patient program called Insight Cares to help appropriate patients and their healthcare providers access their prescribed medications. So for eligible patients, Insight Cares offers prescription insurance verification and prior authorization support, free drug and copay assistance for those who qualify under the program's terms and conditions, as well as ongoing education and support from a representative. So for patients who have concerns about access to their prescribed medications, please contact Insight Cares for assistance. So for information for patient access, it can be found at www.insightcares.com. Once again, that's www.insightcares.com for more information there. And we highly suggest that eligible patients enroll, even if you don't think that you'll need assistance initially, because circumstances can change at any time. And if an eligible patient is enrolled, we will be able to help that individual more quickly if needed. And then just lastly, on clinical trials, we are currently enrolling eligible patients in clinical trials for MPNs. So if you're interested, please contact your healthcare provider. Detailed information about Insight's clinical trials can be found at insightclinicaltrials.com. Once again, that's insightclinicaltrials.com. So thank you so much, Anne. I know I just have a few minutes and you're running long, so I just wanted to say thanks again. Programs like this really help and allow Insight to use our resources to improve the lives of individuals most impacted by the diseases in which we work. So thanks again.
Thank you very much, Kristen. That was very informative. And we'll move on to Geron Corporation. Dr. Faye Feller, are you with us?
Hi, Anne.
Hi, Faye. How are you?
Good. How are you? Oh, okay. Here I am. Thanks for having us. Thanks for having me. It's really great, and how you bring patients and providers and the research community together. Really appreciate your efforts and MPN advocacy. So my name is Faye Feller, and I'm head of clinical development here at Geron. We are a late-stage biopharmaceutical company developing imetelstat, which is an inhibitor of telomerase for the treatment of hematologic myeloid malignancies. We recently completed a phase 2 study of imetelstat in intermediate 2 and high-risk myelofibrosis patients who were relapsed after a refractory to JAK inhibitor treatment. This study, you may be familiar with, is known as MYF 2001 or EMBARK, and it showed a potential for survival benefit and an encouraging symptom response rate. So subsequently, we have recently opened a phase 3 study in intermediate 2 and high-risk myelofibrosis patients who are refractory to JAK inhibitor treatment. This study is known as MYF 3001 or IMPACT-MF. It's an open-label, randomized control trial comparing imetelstat to best available therapy. And our primary endpoint for the trial is overall survival. Symptom response, of course, is a key secondary endpoint. We plan on over 100 sites to be open globally. We are currently open for enrollment, and you can find additional details at geron.com at our website, or as well as on clinicaltrials.gov. And we look forward to continuing to work together to improve the lives of myelofibrosis patients. Thanks.
Thank you so much, Dr. Feller. We really appreciate it. And it's exciting because, you know, as Dr. Mesa mentioned, there are other drugs in trials that are not JAK inhibitors that other, you know, patients may not need. But we will move along. Thank you so much. We'll hear from Obvi. Brian Murray, are you with us, Brian?
I'm here. Can you hear me, Anne?
Yes. Hi, Brian.
Great, fantastic. Hello, everyone. My name is Brian Murray, and I'm Assistant Scientific Director working with AbbVie. Many of you are likely familiar with AbbVie. We are a global pharmaceutical company and leader in the development of therapies for blood cancers. In the space of myelofibrosis, we are evaluating an investigational agent known as Nevidiclax. This is an oral small molecule that binds to two pro-survival proteins called BCL-XL and BCL-2. Myelofibrosis cells will often hijack the BCL-XL pathway in order to keep themselves alive. And we've demonstrated some synergistic activity with Nevidiclax and ruxolitinib in our preclinical studies. I want to talk to you today primarily about 3 clinical trials that are actively enrolling, to give you some more information that involve the evaluation of Nevidiclax and ruxolitinib in combination. The first is a phase 2 study. It's called REFINE. Sometimes you'll see it referred to as M16109. And we're currently looking for patients in 3 different cohorts. 2 of the cohorts are investigating the combination of Nevidiclax and ruxolitinib, and are for patients who have either progressed on the ruxolitinib as measured by spleen size enlargement, or in untreated patients who have not received ruxolitinib. We're also investigating Nevidiclax as a monotherapy in one of our cohorts. We have over 25 sites in the US, and we are actively seeking patients. So if you are interested and think you might be eligible, please contact your treating physician. In addition to this phase 2 study, we have 2 phase 3 studies, Transform 1, which is our phase 3 study evaluating Nevidiclax and ruxolitinib versus ruxolitinib and placebo in patients who have received no prior treatment for the myelofibrosis, so no JAK inhibitor. And Transform 2, which is evaluating the same combination versus best available care. in patients who have progressed on ruxolitinib. So these studies activated sometime last fall, and we're opening new studies almost every week. We're seeking new patients for all 3 of these studies. The last little plug I want to mention is if you want more information on these studies, please go to myelofibrosisresearch.com. You'll find more information there. There's a handy patient questionnaire that helps you determine if you're eligible for one or more of the studies, and will also match you to the nearest institution that has the study of interest open. So again, myelofibrosisresearch, all one word.com, and you can find more information there. Thanks so much to Anne, Kathleen, and everyone at MPN Advocacy and Education International for allowing me to speak. I hope you enjoyed the conversation, and thank you. That's it from me.
Thank you very much. I really appreciate it. And it's always good to know what's going on. And I'm glad I encourage our patients to hear this and understand. Is that Diana?
Yes.
Hi,
hello,
this is Diana Stefani Hunyada. Am I saying that correctly?
Hunyadi, thank you.
Okay, and Diana is with CTI Biopharma. Thanks for joining us.
Thank you very much for this time. I'm an executive medical director in medical affairs with CTI Biopharma, and really, thank you so much to you and your team for putting together a yet new successful clinical forum for patient education. And thank you for the opportunity to tell you all about our work, exciting work here at CTI. As many of you know, we are developing pacritinib, which is a JAK2 IRAK1 inhibitor for patients living with myelofibrosis and also experience low blood counts. Our particular focus currently is on patients with severe thrombocytopenia, or in other words, low platelets, because it's clearly recognized that these patients often have a more advanced disease and fewer treatment options, unfortunately. Our compound pacritinib has already been studied in over 1,000 patients, and that includes 2 phase 3 studies with patients with myelofibrosis. And both of these studies, which are called PERSIST-1 and PERSIST-2, pacritinib was more effective than best available therapy in reducing spleen volume, met this endpoint. We have also completed a phase 2 study called PAC-203, which actually confirmed the clinical efficacy in patients who have been previously treated with ruxolitinib, even among patients with severe thrombocytopenia. Currently, we're enrolling in our pivotal phase 3 study it's called Pacifica. And it's a study of pacritinib versus physician's choice therapy. Pacifica enrolls patients with myelofibrosis.
We just lost you, Diana. I believe we lost your connection, Diana. So we're going to move on. If she can come back, that would be great. We're going to move on to Kartos. Kartos is one of our partners as well, and we're going to hear from Nish Saini.
Yeah. Hi, Anne. Can you hear me?
How are you?
I'm very good. How are you? Thank you so much for giving me the opportunity today. So, yes, my name is Nish Saini. I work for Kartos Therapeutics in the Medical Affairs Group. Really grateful to have the opportunity today to listen to some of the discussions and really to better understand some of the issues you as individual patients are facing around symptom burden management. So it's been very, very interesting for me. Now, I'm sure many of you have probably not heard of Kartos Therapeutics. We're a relatively small, privately owned biotech company. We've got about 65 employees at the moment. We're based in the San Francisco area in California. There was, you can probably tell from my accent, I'm actually from the UK. I'm based in London. And our company's focus really is the development of novel targeted therapies that have the potential to meaningfully improve the lives of patients with cancer. And we're currently developing an oral investigational agent called KRT-232, which is actually being developed across a number of different blood cancers and solid tumors. But a real major focus of our development of the compound is in myelofibrosis, where we actually have 4 ongoing studies at the moment. Now, KRT232 actually targets a protein called MDM2, and MDM2 is a key regulator of a very important tumor suppressor protein that you may have heard of called P53. And P53 is often referred to as the guardian of the genome, and it actually plays a really critical role in the natural life cycle of all cells within the human body. And the function of P53 really relies on the existence of a very delicate balance between its levels and those of MDM2 within the cell. Now, unfortunately, in myelofibrosis, cells can actually abnormally increase their MDM2 levels, and they can shut down the ability of P53 to fight cancer. So CARTOS is exploring the potential of 232 to inhibit those high levels of MDM2 that can be found in myelofibrosis, and thereby restore the ability of P53 to actually kill cancer cells. Now, we were fortunate enough to present some initial quite encouraging data demonstrating the potential of that concept at the European Hematology Association Congress last year. And as a result of that, we've now actually opened a large randomized phase 3 study, which will be going on globally, called the BOREAS trial, BOREAS. And that's going to compare KRT232 with best available treatment in myelofibrosis patients whose disease has progressed or has failed to respond to a JAK inhibitor like ruxolitinib or fedratinib. Now, we've just launched the study website. It's called boreas-trial.com, and you can go there and find more information about the study and where it's being conducted. And obviously, you can find more from your physician as well. And I believe more details on that study are also available on the clinical trial section of the MPN Advocacy and Education International website. So in addition to the BOREAS trial, we have 3 other studies in myelofibrosis where we're exploring the potential of 232. One of those studies is in combination with ruxolitinib in patients who may not have an optimal response to ruxolitinib. Another study is looking at combining 232 with another novel investigational agent from a class of drugs called tyrosine kinase inhibitors in patients who are relapsed, refractory, or intolerant of JAK inhibitors. And we're actually even exploring 232 in a frontline setting in patients who have not yet received any treatment with a JAK inhibitor. So we're a small company, but I think you get a sense that there's a lot going on, and we really have a strong commitment to the development of novel treatment approaches in myelofibrosis. So that's a very quick summary. Thank you very much for the opportunity today to share this brief update. We're really excited to engage with you, the patient community, and to collaborate with groups like MPN Education and Advocacy, and we look forward to continued partnership moving forward. So thank you very much.
You're very welcome, and thank you, Nish. And we will be in touch. And I thought you were from Texas. Just kidding. So we're going to move right along to our partner in Constellation, and we are going to hear from Shani. How are you?
How are you, Anne?
We're good.
Yeah.
Nice to see you.
Likewise, and I can see you can hear me well. Yes. So thank you for this great opportunity to be part of this fantastic webinar. So hi all again, my name is Shani Liao. I'm the Field Medical Director at Constellation Pharmaceutical Medical Affairs. We are a Massachusetts-based biotech company with well over 12 years of discovery and development history, focused on epigenetics and cancer biology. Our drug candidates, which were all internally discovered, are the products of our expertise in gene targeting and in diseases where gene regulation and control matters. Our lead compound is an investigational BET inhibitor called pelabresib, also goes by the name of CPI-0610, that we are developing as a potential treatment of myelofibrosis. Constellation is currently conducting a phase 2 clinical trial of CPI-0610 in myelofibrosis, and more recently, a larger phase 3 trial called MANIFEST-2, not to be confused with the name, has also been initiated for frontline setting in combination with ruxolitinib. For more information, you can find both the MANIFEST and the phase 3 MANIFEST-2 trial at clinicaltrial.gov, or just simply check out our website at constellationpharma.com. So we all recognize that we need new therapies for MS patients and address the areas of unmet need. And we are working hard at Constellation to develop such a therapy. Our clinical and research team are deeply invested in a scientific approach to bringing therapies to patients. Our interest and commitment to patients and caregivers extends across the MPN community as we have additional plans for collaborative and early stage programs that have utility in MS and other MPNs in the future. I applaud this community of patients and caregivers suffering from the consequences of MPN. It truly inspires us to work every day to develop these new therapies. And a final thank you to Anne and the MPN Advocacy and Education International, as well as the distinguished panels for the opportunity today. Back to you, Anne.
Thank you very much, Shani. We really appreciate it. And again, to our patients, thank you so much for being with us. And to Drs. Pettit and Dr. Mesa. And you can see our, we have many, many partners, and there are lots of things happening in the MPN space. If I were a patient, I'm not. I've been around in this space for 17 years, but if I were a patient, I would have to feel a little bit of hope right now because there's so much going on. And you've heard from some patients that, one who has converted and, is going to address that issue and decide what is best for her, and from George and from Julia. And we just thank you all very, very much. And we thank our partners. Thank you and have a good day and stay safe and call us if you need us. Thank you.